1. Okay, so this is chapter 50 for adult med surg, and we're going to cover the peripheral nervous system. We're not going to cover every single disorder in here, but we are going to try to get through the important ones like multiple sclerosis, myasthenia gravis. Okay, I'm going to share my screen and I'm going to pull up the PowerPoint and I'm going to get rid of our faces. So here we go. So chapter 50 is about nursing care of patients with peripheral nervous system disorders. So what are we going to do? We're going to talk about the disorders that are caused by a disruption of the peripheral nervous system, explain what goes wrong, the pathophys, signs, symptoms, complications, therapeutic measures that are used. We'll also talk about the nursing diagnoses and nursing interventions that are associated with these diseases. And we'll talk about how do we evaluate the effectiveness of the care that we're providing. In other words, did it work? Did what we do work? All right, so first one, we're going to talk about multiple sclerosis, also known as MS. Okay, MS. So multiple sclerosis is degeneration of the myelin sheath. So in other words, there's a protective covering around nerve cells that's called a myelin sheath. And we believe it's autoimmune, but I don't know, idiopathic, we're not sure. For whatever reason that people get this, that myelin sheath starts to break down and the nerves get inflamed. So the nerve impulses, the nerves can't communicate the way they normally do. So as you can see down here, etiology unknown. So autoimmune is really the thing that we go with, right? We do believe it's autoimmune, but we're not 100% sure. So in other words, the patient's own immune system is what's attacking those myelin sheaths and breaking them down. And that's the cause, we think. So it even gives you a nice little picture here of what it's supposed to look like and then what happens as it starts to break down. And when it breaks down to this point, it can't communicate. So your spinal cord can't communicate with these nerves over here because this has broken down. And so that's the cause of the symptoms. Well, what are the symptoms? So muscle weakness, that's pretty vague. Numbness, fatigue, slurred speech, vision disturbances. I'm going to elaborate on this a little bit. When they say vision disturbances, I'm going to tell you that blurred vision is one of the first early symptoms, right? And that's usually how it starts. It's usually females, by the way, predominantly females that get MS. But blurred vision, they'll complain about, oh, I don't know what's wrong. Maybe I need to see the eye doctor. Having trouble. Things look blurry. And that is one of the first signs. Now, don't freak out and say, well, I get blurred vision. Doesn't mean you have MS. There are other symptoms that go along with it. So that numbness is usually with numbness and tingling. And the word for numbness and tingling is paresthesia, right? So it's like hitting your funny bone. They'll have this numbness and tingling in extremities, weak muscles, feel like they can't move, fatigue, slurred speech, sounding like they're drunk, vertigo, which is dizziness, if you don't know that, right? Dizziness, and it's also known as syncope, which is kind of like passing out, okay? And then they'll have, some of these symptoms look familiar, ataxia, that weird, shuffling gait, dysphagia, trouble swallowing, bowel and bladder problems. They will have difficulty because remember, your bowels and bladder, in order for you to be able to hold them, right? So, oh, I got to go to the bathroom, but you can wait until you get to the bathroom before you go, right? That's because your nervous system's working right. And there's communication between your brain and down at your bladder, and your rectum, uranus, and your urethra. Like, okay, don't go yet. We're not at the bathroom yet. Well, because of this breakdown of the myelin sheaths, they will typically have issues of incontinence, like, why can't I hold my urine anymore? Sexual dysfunction. And then that has to do with the innervation as well. There's no communication. So especially if men get it, they will have erectile dysfunction, won't be able to get an erection. And mood alterations that are extreme. There's a term that's called mood lability, okay? So lability, and I'm going to put in parentheses, labile, means up and down. I'm happy, I'm sad, I'm happy, I'm sad, I'm happy, I'm sad. Their moods all over the place, just very strange, okay? So other manifestations, MS is weird that it'll wax and wane, which means it'll have remissions so that they're not having any symptoms for a while. And they're like, wow, this is great. But then they will have exacerbations where they will not even be able to walk sometimes, right? And usually when they have exacerbations, it has to do with high stressful events or illness unrelated to the MS, like they get the flu, right? Or something like that. And that will cause them to go into an exacerbation of the MS. And immobility, you know, the inability to move. And when people with MS pass away, it's usually because of infectious processes that happen, because oftentimes the treatment for MS is an immunomodulating drug or something that will stop the immune system from trying to kill the patient, right? But if we shut down the patient's immune system, then they're at risk for all types of infections. And when we get to some meds, we'll talk about that a little bit more. How do we diagnose MS? Well, we're going to always do a history and physical. We do that for everybody. We may do a lumbar puncture and do an analysis of the cerebrospinal fluid, right? Spinal tap. MRI to look at the nerve communication to say, hey, is there a problem here? And then how do we treat it? What are the interventions? So, you know, there are lots of things that we can do. We can't cure it, but we can sometimes manage the symptoms. And so what you need to know, steroids, and steroids, we mean like corticosteroids. And I'm going to actually put that here in parentheses, corticosteroids, which are drugs like prednisone. Because what steroids do is two things. They decrease inflammation, but they also suppress immune response, which if this is autoimmune, that's what we want to happen, right? The side effect is the thing that we want from the steroids as much as we want the action of it, okay? We're not going to talk about interferon, but we will talk about immunosuppressant agents. So these are medications that suppress the bone marrow. They're considered myelosuppressive meds. Because if I suppress your bone marrow is where red blood cells, platelets, and white blood cells are made. If I suppress the bone marrow, can't make white blood cells. Can't make white blood cells, your white blood cells can't kill you, but you're also going to be at a huge risk for infection. There are instances where anti-seizure meds are used, but muscle relaxers, I'm going to talk about those. And the ones that we need to talk about, and I have a separate PowerPoint on these, cyclobenzaprine, which is also known as Flexeril, which is a very like low-key muscle relaxant. And then we have the Queen Mother, which is baclofen, right? And baclofen is a big gun, if you will, muscle relaxer. And why are we relaxing their muscles if it's a neurological disease? Because the problem with the nerve lack of stimulation causes the problems with the muscles. So if we relax the muscles, they don't have as many tremors, right? Don't worry about plasmapheresis. We are not going to get into that. You won't be asked about it. But remember, no man is an island. What does that mean? Always reach out to other therapies for help. Patient can benefit from physical therapy, occupational therapy, speech therapy. And just to elaborate on this for a little bit more, I just want to make sure you know. So physical therapy is all about gait, right? And transfers, okay? So when you think PT, you're thinking about, you know, getting up and down and walking. Occupational therapy is all about activities of daily living, ADLs, brushing your hair, brushing your teeth, making a meal, eating a meal, right? And then speech therapy is all about speech, right, and language, and it's also about swallowing, right? Yeah, the ability to eat and swallow, okay? So that's important for you guys to know. All right. That's it for multiple sclerosis. Myasthenia gravis, I am going to touch on. I'm not testing you on it. You should at least be familiar with the word, right? Myasthenia gravis. This is an autoimmune disorder, okay? And what happens is there are your antibodies, and I'm actually going to just change this. Let's make this autoimmune. So autoimmune, okay? The patient's antibodies actually destroy acetylcholine receptors. So acetylcholine is a neurotransmitter, and I'm going to put that over here for you guys. And you need to at least know these words. So that's a neurotransmitter that allows muscles and nerves to communicate. And with myasthenia gravis, I'm going to give you a little hint of what to remember if you ever see it again. Just remember ragdoll. Okay, I'll put that here. Ragdoll. When you see myasthenia gravis, you think ragdoll, because when those acetylcholine receptors get destroyed, then there's no acetylcholine to make the muscles move, and they lose muscle strength that's voluntary. So they're floppy like a rag doll. I had a pit bull that had myasthenia gravis. Very sad. Okay. They get into a lot about the receptor sites. Not going to get into it, but just, you know, the etiology really is autoimmune. This PowerPoint's a little old. They're almost 100% certain. A lot of these disorders that are autoimmune are linked to some viruses, particularly mono, but that's not 100% certain. So that's why I won't put it on the PowerPoint. They give you the signs and symptoms. Okay, we're going to go right past them because we're not going to get into the details about that. ALS, which is called Lou Gehrig's disease, not going to get into that right now either. We have a lot of other fish that we need to fry. Guillain-Barré, right? Same thing. Not even going to get into that because we have to get into stroke and seizures and so many other things. We're not going to talk about post-polio syndrome because as long as you get immunized, you don't get polio. Restless leg syndrome, the board does not ask about, and neither does ATI. But I am going to just go through real quick. Trigeminal neuropathy, which is also called, right, I'm going to put AKA, trigeminal neuralgia. When you see algia at the end, we're talking about pain, discomfort. And so neuralgia, pain, discomfort of the nerves, right? Trigeminal has to do with 3 of the cranial nerves. And the only reason I'm even covering this is because I want you to know that there is a question, and I don't usually do this, but here I will. There's a question ATI has that asks about treatment that's off-label treatment for trigeminal neuralgia. And the answer is carbamazepine. Carbamazepine, right, is an anti-seizure medication, but it works for treating trigeminal neuralgia. I'm not even going to get into Bell's palsy except just to describe what it is, just so you're familiar with it. I'm not testing you on it. Neither will ATI. Probably the board won't either, okay? Bell's palsy is also, it's a cranial nerve problem, comes on basically out of nowhere, and the patient will just suddenly have this droop in their face on one side. And it almost looks like they've had a stroke, but it's nowhere else on the body. It's that one side of the face. And the way it comes is the way it goes. And ask me why, and I'll go, idiopathic, right? Bell's palsy is very strange. So here's trigeminal neuralgia. They get into a lot of detail. That is the cranial nerve, the trigeminal nerve. And see how it innervates the eyes and up here, the maxilla and mandible, your ability to chew and speak and stuff. Patient will have all this pain in here. So just remember, carbamazepine, right? Okay. And for this chapter, I do believe we are done. Make sure you understand multiple sclerosis. That is the big one. ATI and the Board of Nursing love to ask about multiple sclerosis. Okay, that's one of their favorite topics. They will ask about care planning for a patient with multiple sclerosis. They will ask about interventions, nursing interventions for multiple sclerosis. So that's the one that you want to know. Progressive and degenerative, like Parkinson's. We don't know why, but we think it's autoimmune. So that's kind of like, and then the symptoms, the difficulty with gait, the difficulty with vision, right? And it comes and it goes, comes and it goes. Okay. And then the baclofen, and that's something that we'll talk about when we get to that one. So I am going to end this and do Q&A with my students. And that is the end of this chapter.